Hello friends, welcome to my new video, and in this video we will discuss about the various reasoning questions of the blood. So let us start. So question is that why the prothrombin time may be prolonged after the administration of the antibiotics when the bile duct is obstructed and in malabsorption syndrome and in liver disease. So answer is that prothrombin time is prolonged in A, B and C because of effective vitamin K deficiency. And first question is after the administration of antibiotic, why the prothrombin time may be prolonged? So because the antibiotic that eliminate the gastrointestinal bacteria which manufacture the vitamin K. Then in bile duct obstruction, why the prothrombin time may be prolonged? So obstruction of the bile duct reduces the availability of the bile salts in the gut which impairs absorption of the fat. Then in malabsorption syndrome. So impairment of the fat absorption adversely affects the absorption of the fat soluble vitamins such as vitamin K. And absorption of the vitamin K is reduced also in malabsorption syndrome. Now in liver disease, D. Prothrombin time is prolonged because the liver cannot manufacture sufficient prothrombin. Fish oil prolongs the bleeding time when ingested. So fish oil that contains certain fatty acids that decreases the arachidonic acid release from the platelet membrane phospholipids, and therefore the synthesis of the thromboxane A2 decreases. So these fish oils prolong the bleeding time when ingested. Then renal disease causes anemia. Why? So as the kidney is the major source of erythropoietin. Now in chronic renal disease that reduces renal mass significantly that produce anemia. Anemia is also produced following the nephrectomy. Now in such condition the erythropoietin produced by the liver fails to meet the normal demand of the erythropoiesis as the amount secreted from the liver is not adequate. So there is a erythropoiesis process is decreased, so that renal disease that causes anemia. Now a patient with normal blood glucose but an elevated glycosylated hemoglobin was diagnosed as having diabetes mellitus. Now hemoglobin is non-enzymatically glycosylated by the glucose and that enters the erythrocytes. The amount of the glycosylated hemoglobin is proportionate to blood glucose concentration and is normally about 5%. The rate of the glycosylation is slow and therefore the glycosylated hemoglobin level reflects the average blood glucose concentration over the preceding 6 to 8 weeks, and that serves as an index of long-term control of diabetes mellitus. So a patient who is mostly careless about the controlling his hyperglycemia and blood sugar and takes an insulin injection only before visiting the physician would have a normal blood glucose, but his glycosylated hemoglobin would remain elevated. So that a patient with normal blood glucose but an elevated glycosylated hemoglobin was diagnosed as having diabetes mellitus. Now sickling occurs only in the deoxygenated hemoglobin, not occur in oxyhemoglobin. So sickling occurs only in deoxygenated hemoglobin. Sickling does not occur in oxyhemoglobin because the conformational change that occur with the oxygenation hides the sticky receptors in the deeper region of the molecules so that they are not present on the surface and no sickling can occur. Now sickling is less in red cells that have more fetal hemoglobin because the fetal hemoglobin has sticky receptors but no sticky patches. Hence, in effect, fetal hemoglobin blocks the sticky patches of the HbS. As a result, they prevent the formation of the long polymers of HbS. So, in this figure, we can see the sticky receptors and sticky patches in sickle cell anemia. So, this one is a deoxygenated hemoglobin S and this is a oxygenated hemoglobin S. So polymerization of the deoxygenated hemoglobin S, this one is a sticky patch and this one is a sticky receptor. And here in oxygenated hemoglobin S, sticky receptors are hidden. And this below figure, there is a lack of the polymerization of the deoxygenated hemoglobin S in the presence of fetal hemoglobin. Only trimers are formed. Shortly after the birth, the hemoglobin concentration of infant increases rapidly. Why? So shortly after the birth, the hemoglobin value of the normal infants increases rapidly with the hemoglobin on the first day of the life being about 18.5 gram per deciliter. And this is due to two main reasons. First is there is transfusion of the red blood cells from the placenta to the infant and hemoglobin values are significantly higher in infants in whom the cord is not tied for a few minutes after the delivery, that allowing the extraplacental blood to pass into the infant. And second reason is that there is a rapid destruction of the plasma volume in the neonate resulting in hemoconcentration, and the reduction in the plasma volume allows the infant to accommodate the extramaternal blood cells obtained through the transfusion. So because of these two reasons, shortly after the birth, the hemoglobin concentration of the infant increases very rapidly. Then, although the hemoglobin is a colored compound, its concentration in the blood is estimated by colorimetry only after adding acid or alkali to it. So answer is that being a colored substance, the hemoglobin concentration of the blood sample can be easily estimated by comparing its color to that of reference hemoglobin solution. However, difficulty in colorimetry is posed by the fact that the color of the hemoglobin is not constant. It is bright red when fully oxygenated and bluish red when deoxygenated. Hence, before the colorimetry, it is important to oxygenate the hemoglobin completely by oxyhemoglobin method or to either denature it using acid by acid hematine method or alkali by using alkali by alkali hematine method or cyanide by cyan methemoglobin method. Now, sickle cell has a high mechanical fragility but low osmotic fragility. Why? So, in sickle cell hemoglobin, the alpha chains are normal but beta chains are abnormal with valine residue at position 6 instead of the usual glutamic acid. Now this substitution that results in the formation of the certain reactive sites that is known as sticky patch on the beta chain, which bind to sticky receptors on the alpha chain of the sickle cell hemoglobin. This binding that causes polymerization of the hemoglobin S, forming a long fibrous precipitates, and the precipitates distort the erythrocytes, making it sickle shaped. Since the polymerization that results in a fewer molecules of the hemoglobin, and the osmotic pressure that is exerted by the hemoglobin decreases, and the sickle cell becomes dehydrated. For the same reason, the sickle cell can imbibe more water without bursting, and its osmotic fragility is lower than that of the normal cell. However, its mechanical fragility is higher because polymerization of the hemoglobin deforms the membrane and makes it rigid, and the membrane also gets altered chemically so that it favors the deposition of the immunoglobulin G and complement on its surface. So because of all these reasons, the sickle cell has a high mechanical fragility but a low osmotic fragility. The hemolysis in a sickle cell is both intravascular and extravascular. So hemolysis is both intravascular and extravascular. Intravascular hemolysis occurs due to cell lysis caused by complement activation, and it also occurs due to fragmentation of the rigid cells due to mechanical stress as it passes through narrow capillaries, and extravascular hemolysis that occurs due to excessive phagocytosis of the immunoglobulin G coated sickle cell by macrophages in splenic sinusoids. So in this way, the hemolysis in sickle cell is both intravascular and extravascular. Sickling is less in the cells having a higher concentration of the fetal hemoglobin. Why? So sickling is less in the red cells that have more fetal hemoglobin because the fetal hemoglobin has a sticky receptors but no sticky patches. Hence in effect, fetal hemoglobin blocks the sticky patches of the sickle cell hemoglobin. As a result, they prevent the formation of the long polymers of the sickle cell hemoglobin, so that the sickling is less in the cells having a higher concentration of the fetal hemoglobin. Now, Kernicterus occurs only in unconjugated bilirubinemia. Why? So, albumin molecule has two binding sites for bilirubin. First is high affinity site and second is low affinity site. High affinity sites on albumin molecule can bind unconjugated bilirubin up to a concentration of 20 mg per deciliter. Now unconjugated bilirubin in excess of 20 mg per deciliter is bound to low affinity site on albumin and dissociates readily. Being lipid soluble, the unconjugated bilirubin can cross the blood-brain barrier and it penetrates the adult brain in small amounts, but in infants, hyperbilirubinemia in excess of the 20 mg per deciliter that results in a neurological disorders, and that is known as kernicterus due to deposition of the bilirubin in the lipid-rich basal ganglia. So that the kernicterus that occurs only in unconjugated bilirubinemia. Which plasma protein normally contributes to maximum to blood viscosity and why? So owing to their size and particularly their shape, the plasma protein like fibrinogen that greatly contribute to the blood viscosity. Then feces darken on standing in the air. Why? So most of the urobilinogen formed in the intestine are excreted in the feces. The darkening of the feces on standing in air is due to conversion of the fecal urobilinogen. That compound is colorless to urobilins, and that is a colored compound, so that feces darken on standing in air. The skin becomes yellow in jaundice, but it is not diagnostic of jaundice. Why? So the term jaundice or icterus that refers to yellowish discoloration of the skin and mucous membranes caused by hyperbilirubinemia. And clinical jaundice is apparent when the serum bilirubin exceeds 2 milligram per deciliter. Now in hypothyroid states, the serum carotene level is elevated and also the skin becomes yellow. And this skin condition differs from that observed in jaundice in that the sclera of the eye is not yellow. The yellowing of the sclera that is prominent only in jaundice because the elastase in the sclera that has a high affinity for binding with bilirubin, so that if the skin becomes yellow in jaundice but it is not a diagnostic of jaundice. Now, why is the water loss from airways greater in cold weather than in hot weather? So, the temperature of the airway is constant at 37 degrees centigrade and air in the airway is fully saturated with water vapor. Now, water vapor pressure at 37 degrees centigrade is 47 millimeter of mercury. Now in cold weather the temperature is low and hence the water vapor pressure is also lower. Therefore, to bring the water vapor pressure to 47 millimeter of mercury in the airway, it takes more water from the body in winter than in summer. So that the water loss from the airway is greater in the cold weather than in hot weather. Now conjugated bilirubinemia is choleric, but unconjugated bilirubinemia is acholeric. Why? So unconjugated bilirubin that is insoluble in water and it is transported in the plasma in bound form with albumin. Since the albumin is not filtered into the urine, unconjugated bilirubin does not appear in urine. Hence in unconjugated bilirubinemia, the jaundice is acholeric, no bile in the urine, and this process is seen in figure A. Now conjugated bilirubin that is water soluble and is present in the plasma in dissolved form and it gets easily filtered into the urine. Hence in conjugated bilirubinemia the jaundice is choleric, bile pigment present in the urine. So this process or this mechanism is illustrated in figure B. Now erythrocyte sedimentation rate increases in pregnancy and inflammatory disease. Why? So the most important factor that determines the erythrocyte sedimentation rate is extent of the Rolex formation by the erythrocytes, and Rolex formation is determined mainly by the nature of the plasma. Increased Rolex formation occurs when the plasma contains increased amounts of the fibrinogen as in pregnancy and in serum globulin as in inflammatory disease, so that ESR increases in pregnancy and inflammatory disease. Kernicterus that occurs only when the plasma unconjugated bilirubin exceeds 20 milligram per deciliter. Why? So the albumin molecule that has two binding sites for bilirubin, a high affinity site and low affinity site. High affinity site on albumin molecule can bind unconjugated bilirubin up to a concentration of 20 milligram per deciliter. And unconjugated bilirubin in excess of the 20 milligram per deciliter is bound to low affinity site on albumin so that it can easily dissociate. Being a lipid soluble, the unconjugated bilirubin can cross the blood-brain barrier and it penetrates the adult brain in small amounts, but in infants the hyperbilirubinemia in excess of the 20 milligram per deciliter that results in a neurological disorder, and that is known as Kernicterus, and in which there is a deposition of the bilirubin that occurs in part of the part of the brain, and that is basal ganglia. So that Kernicterus occurs only when the plasma unconjugated bilirubin exceeds 20 milligram per deciliter. With increasing the severity of the hepatocellular jaundice, the urine urobilirubin first increases and then decreases. Why? So initial rise in the urine urobilinogen, that is due to reduction in the hepatic reuptake of the urobilinogen absorbed from the intestine into the blood. Hence, the urobilinogen is eliminated larger amounts in the urine. The subsequent fall in the urine urobilinogen is due to reduced excretion of the bilirubin into the intestine, with consequent reduction in the intestinal urobilinogen synthesis, so that with increasing severity of the hepatocellular jaundice, the urine urobilirubin first increases and then decreases. Plasma protein concentration often falls during mid-pregnancy despite an increase in the hepatic synthesis of globulin. Why? So, the mid-pregnancy fall in the total plasma protein concentration is largely due to hemodilution and occurs despite the increase in hepatic synthesis of globulin. Now, marrow aspiration is painful. Why? So the merocynocytes that connect the arterial capillaries with the venules, developing the blood cells that lie outside the sinusoids. Unlike the spleen, the merocynocytes that forms a closed system with no openings into the extravascular spaces. Hence the newly formed cells have to cross the sinusoids wall to enter into the circulation, and the sinusoids are innervated by the sensory nerve fibers. So this now explains why the narrow aspiration is painful. Vitamin B12 deficiency that results in macrocytes, and iron deficiency results in microcytes. Why? The formation of the microcytes in iron deficiency and macrocytes in vitamin B12 are linked to the mitotic activity of the erythrocytic precursors. Mitosis that stops when the hemoglobin inside the normoblast reaches the critical concentration of about 20 gram per deciliter. At such concentration, the hemoglobin that enters the nucleus through the nuclear pores and reacts with the nuclear histone. The reaction inhibits the DNA replication and thereby disables mitosis. In iron deficiency, the critical hemoglobin concentration is reached later and allowing the mitosis to continue longer and resulting in the formation of the small red blood cells. Conversely, the vitamin B12 that is essential for the DNA synthesis, and therefore its deficiency inhibits the mitosis that results in the formation of the megaloblast and macrocytes. So in this way, the vitamin B12 deficiency that results in macrocytes and iron deficiency that results in microcytes. Extramedullary hemopoiesis is the commonest in infant and young children. So extramedullary hemopoiesis. So the spleen, liver and lymph node that resume their hemopoietic activity when there is an excess demand for the blood cell formation that cannot be met with the bone marrow hyperactivity alone. So such hemopoiesis that occurs outside the bone marrow, that is known as extramedullary hemopoiesis, and that is very common in infants and young children in whom the entire marrow cavity is occupied by the red marrow or hemopoietic marrow, that leaving a little space for the expansion of the marrow cavity, so that the extramedullary hemopoiesis is very common in infant and young children. Now, chronic inflammation, that is associated with hypoproteinemia, but acute inflammation is associated with hyperproteinemia. Why? So, hypoproteinemia in chronic inflammation is due to inhibition of the hepatic synthesis of albumin by inflammatory mediators. So, hyperproteinemia is seen in acute inflammation. Now, globulins that increases sharply during any acute inflammation, and these are known as acute phase protein. They include C-reactive protein, so called because it reacts with the C polysaccharide of the pneumococci. Although an acute phase protein, C-reactive proteins also increase in chronic inflammation. Now lastly, I want feedback from you that if you like this type of video related to reasoning questions of the different systems of physiology, then please write down in comment section. Thank you very much.